Your results suggested that you crack something which is more important. But if you
Yeah.
look around other telehealth platforms, even if I talk about eSanjeevani, 94%, you have 94% plus health behavior adoption versus 20% or so useful consultations rate by other platforms. So when people see some semi literate rural women, they assume limited capacity. What are
Right.
they getting wrong about these women can actually accomplish?
Okay. For the e-Sanjeevani itself, the e-Sanjeevani was structured so that there could be access, but they did not take into consideration the community's skill sets and what the community can do, because you have to log in and you have to enter all your data. Many of them don't have smartphones, many of them don't have networks, and they're not literate. And then once you have entered all the data, you just have to wait to get an appointment. Then you would have to go to a center, which is invariably the PHC or CHC. And you don't know when you get called in. A poor person cannot afford to lose a day's wages to be able to go and indefinitely wait for an appointment. One, it is not as accessible. It has to be done at the PHC and CHC, and most of the time, PHC, CHC are far away. And the second thing is they are not literate enough. They don't have the devices to access. And the third thing is most of the telehealth applications starts with the nurse or an educated person who has access to all these networks. And here we are trying to provide access to the poorest of the poor in the remotest areas. And that is the big difference, because it needs to be voice enabled or it needs to have a device. And that is what our CHE has. And that is why we have been successful. And the other important part of it is that the community, the CHG, when she connects the community member to our telehealth program, there's a telehealth executive, because the community member and the doctor can speak Hindi, but the language is very different. People don't understand. And therefore, we have a telehealth executive who is also part of the community, who understands the jargon, who understands the language, and able to translate and simplify the doctor's direction and their advice to the community member. And the CHE will follow up with the community. And if there is a problem that it's an elderly person, they don't have anybody to go and get the medicine, the CHE supports them. If they have been referred to the doctor, then if they are not able to go, she goes and finds out what is the problem, why they have not done. And this follow up and the continuum of care, that is missing in most of the telehealth interventions. I think that is the biggest differentiator.